Good afternoon and a warm welcome to everyone present here today. And thank you everyone for joining in for our ninth and final episode of the Inside Implementation webinar series titled Advancing SLT Control in India, Recent Developments, Best Practices, and Challenges in Implementation. The reason we started organizing the Inside Implementation webinar series was to kind of understand and have an on-ground perspective of the facilitators and barriers or the challenges that implementers face in the field of tobacco control. And the objective of this webinar series 4 years ago was to bring together policymakers, practitioners, tobacco control advocates, and people who are working directly and indirectly in the field of tobacco control together on one platform to address tobacco and tobacco control issues in India, in the Southeast Asian region, and also discuss how can we move forward in strengthening these policies and learn from each other. So today's webinar title is on advancing SLT control in India, recent developments, best practices, and challenges in implementation. As we know, smokeless tobacco or SLT in India specifically, according to the Global Adult Tobacco Survey or GATS, we know that 30% of Indian adults use tobacco in any form. And around 20 million adults, that's around 21.4% overall, we regularly consume some type of SLT. In India, some of the major forms of SLT available are pan masala, khaini, zarda, and gutka. Prevalence of smokeless tobacco use is twice in our country, in India, as compared to smoking. And the burden is also huge, creating an urgent kind of public health challenge of more than 0.35 million Indians dying each year due to smokeless tobacco use. In one of the studies that we have conducted at IPH Bangalore on smokeless tobacco, we found that the smokeless tobacco supply chain in India is quite diverse but also integrated. It's bound by information sharing practices and access to infrastructure all across the supply chain, making it difficult to implement smokeless tobacco control policies. And we've also found out that people, with various roles enter the chain on shared economic interests. So across the supply chain, whether it's the wholesaler or the shopkeeper, or at the production and manufacturing unit or packaging, there are varied actors who are entering and exiting the supply chain, making it difficult for enforcement, making it difficult for policy and implementation. And when we look at smokeless tobacco control, one of the central arguments, or one of the central issues that we see is on consumption, on using smokeless tobacco as food. Now, this is an article that was, in 2016, a very dated article that talks about how 70 million Indian women use smokeless tobacco to suppress hunger. So there is a perception that, smokeless tobacco is an alternative form of tobacco. It is less harmful, and it is used as an alternative to food to suppress hunger, thus creating many health-related challenges, policy-related challenges, as well as the implementation. Now, when we look at smokeless tobacco and consumption, we have food laws in India, and we also have tobacco cessation at the user level on ground. But what are these challenges actually being faced in these two domains? So we have with us two speakers for our webinar today. We have Dr. Amit Yadav, who is the Senior Technical Advisor of the Union Southeast Asia Office in New Delhi. And we have Professor Dr. Aruna DS, a dental and public health consultant and also a tobacco cessation specialist. Dr. Amit will be talking about the policy, the slightly macro challenges in the domain of SLT control, which will touch upon the policy, legal implementation challenges, and also on the food laws in India and how does that relate to smokeless tobacco. And Professor Dr. Aruna will be talking about tobacco cessation, which is another important component in terms of consumption, where there are certain challenges in terms of brief advice and mitigating smokeless tobacco use among users at the healthcare setting. So I now invite Dr. Amit to continue with the presentation.
Vivek, Dr. Amit asks if Dr. Aruna can go first.
Sure. So I'll now invite Dr. Aruna DS, who is a dental and public health consultant and a tobacco cessation specialist. Over to you, ma'am.
Can you see?
Yes, ma'am.
Good afternoon, everyone. A warm welcome to all of you for the webinar title. My topic is on challenges and opportunities for smokeless tobacco cessation in India. It is what is smokeless tobacco and cessation? Challenges with respect to knowledge, attitude, and behavior. Health system challenges, the implementation of cessation, number of cessation clinics, lessons from a healthcare perspective. So before I start, I would like to start with the verse like, even a cat that is being driven away never leaves a mouse. Similarly, howsoever poor man may be, he does not leave the use of the tobacco. And this is adapted from Subhashita Ratna Bandagara, 7 Sanskrit verse of unknown date and authorship. Despite being convinced several times about the injurious effects of tobacco, a fool never leave its use, just as the cat does not leave the mouse and eats it away. Probably despite knowing the after effects of consumption, which are depicted pictographically even on the packages of the smokeless tobacco products or the smoking form of the tobacco product packages. So you can see it here. Here the cat is entering the trap of the mouse here. It's compared to the tobacco products, smokeless form of tobacco products, smoking form of tobacco products, or the new nicotine delivery products which are marketed in the matrix of the reduced harm products. So why this is happening? Is this due to the addiction of the nicotine, which is a psychoactive element which is present in the tobacco, or else are there any other factors which are playing a role on this? What is this nicotine addiction? It is a brain disease which derives changes in the brain and is not just a bad habit. And here it is a nicotine addiction is or dependence, it is compared as a chronic relapsing disorder, much on the lines of other chronic diseases like diabetes and hypertension. And this often requires repeated intervention and multiple attempts to quit. And to treat tobacco user effectively, clinicians need to consistently address the tobacco use with the patients, and tobacco users need to be educated, supported, treated, and followed up. So here the nicotine hijacks and rewires the neurotransmitters in the brain. So what is this tobacco use disorder? According to the DSM-5, a problematic pattern of tobacco use leading to clinically significant impairment or distress as manifested by at least 2 of the following occurring within a 12-month period. So either it may be a loss of control, inability to stop using the tobacco, persistent desire or unsuccessful efforts to stop using, craving, a strong desire to use the substance, failure to fulfill the major obligations due to use, a great deal of time is spent obtaining, using, and recovering from the use of substance called as salience, and continued use of substance despite having social or interpersonal problem caused or made worse by the use, important activities are reduced or given up because of the use, substance use in situations where it is physically hazardous, continued use of substance despite having physical or psychological caused or made worse by the use, tolerance, and the withdrawal. Tobacco users maintain minimum serum concentration so as to prevent the withdrawal symptoms, maintain the pleasure or the arousal, and to modulate the mood. They self-titrate the nicotine intake either by inhaling the smoke more intensely, smoking, or dipping more frequently. obstructive vents on low nicotine band cigarettes. So these are the various modes. This is how a person like self-titrate so as to maintain the like pleasure and arousal and to overcome the withdrawal symptoms. So what are the connections like here? So is nicotine dependence is compared to a triangle wherein, so it is not merely the physical dependence which is caused due to the presence of the psychoactive element nicotine, but also because of the behavioral and social connections and the emotional and the psychological components, so which play a major role in the nicotine addiction. So the behavioral and the social connection, so addictive tobacco habit is intimately tied to the user's everyday activities, social cues or triggers in the environment. First an eye-opener use of the tobacco use. So either to facilitate the bowel movements and the emotional or the psychological cues. Tobacco users link tobacco with certain emotions, thoughts, and beliefs. The triggers via the process of withdrawal and the operant conditions. So why we need to know this? A part of quitting involves the breaking those subconscious connections. Important to work with the patients to find the link between the tobacco and their feelings, beliefs that smoke was formed, to help them debunk the negative beliefs of tobacco and the quitting. So here this is how in order to overcome this, the various interventions are also applied. To overcome the physiological or the physical dependence, pharmacotherapy could be implemented, and to overcome the psychological, pharmacotherapy and the behavioral counseling, and for the combating the behavioral component of addiction, behavioral counseling is very much essential. So that's why holistically we need to address the nicotine addiction. Quitting smoke, what are the characteristic features or the unique features of the oral tobacco users? Achieving an alternate oral gratification, we call it as, missing having something in their mouth, a stronger need for oral substitutes, having something in the mouth to take place of a chew, snuff, or a pouch. Behavioral rituals, peer pressures are the powerful influencers. Using healthy alternatives like mint, fennel seeds, elaichi between the lip and the gum maybe help them to substitute. They allow the patient to continue the behavior and yield whatever pressures keep them chewing, but without the danger of the tobacco. So this is where we need to substitute tobacco with the non-tobacco products. The mouth source, we can also motivate them that if they, so what is the feedback which is present in their oral cavity, mouth sores often slow go away and gum problems caused by the smokeless tobacco may stop getting worse. We can just give the feedback that what would be the benefit if they quit the tobacco. The immediate reward. And few people are just, again, even the cue may be the chewing sound, the emotion which is associated with that, the people and the smell. So each of their sense organs are very much accustomed to the use of the smokeless tobacco. That's why many of the smokeless tobacco products are like they are to appeal the customers, either they are the aromatic components are added, then the components to give the refreshing feeling, and component to enhance the taste, or sweeteners, and all these things are added. So how if you can go for how can be need and demand interplay, how useful opportunity can be tapped, and the barriers between the demand and the supply can be again you are seeing the context of can be broken in the context of smokeless tobacco cessation in the Southeast region. So need is what people might benefit from. So here by seeing this, we can say there is an obvious need for the hype in the Southeast Asia region, because as like 21.4% of our tobacco users are of smokeless tobacco in India. High prevalence of the smokeless tobacco use in Southeast Asia and the risk associated with the use of the smokeless tobacco are very much evident. That's why the health benefits of smokeless tobacco cessation is also there. And what is the demand? Demand is what people would be willing to pay for in a market and wish to use it in a system of free healthcare. The supply is what is actually provided by the health system. So here there is an enormous need for SLT cessation, and how we are going to convert these needs into demand for the smokeless tobacco cessation is we need to understand. The demand for the quitting the smokeless tobacco, there is a demand for quitting is less than that for the smoking. It is lower among the women compared to the men. Health system seems to be less sensitized on the issue of smokeless tobacco use and enormous public health gains associated with the smokeless tobacco cessation. The fact that SLT use is deeply embedded in the cultural milieu of the countries of the region, more prevalent in the socioeconomic strata, uneducated individuals and the rural population further complicate the scenario. That's why we need to break the barriers, regulate the aggressive marketing strategy of the tobacco company, attractive packaging and flavoring of the SLT products, address the special barriers, cultural and the gender risk barriers in the region, reach out to the disadvantaged group, either it may be socially rural people reside in the rural area, illiterate and the poor. So how we can maximize this, increase the awareness of the negative health complex impact of the SLT use in the community, educate the community on feasibility of quitting SLT use with the right approach, market the non-health benefits, be it maybe the socioeconomic benefit, cosmetic benefit of Hello?
Sorry, we can hear you. Sorry about the interruption.
Yeah, that's you had unmuted. So now I'm audible, na? Yeah. So take steps to decrease the accessibility and affordability through the regulatory measures and the tax increase. So how the need-demand interplay in the interest of public well-being, efforts should be made aggressively to convert these passive needs into the active demands for the SLT cessation. In this, because we see that there is a passive needs are very huge here, but demand is very suboptimal. So SLT, till SLT users in the countries of the region start demanding quality cessation services. So this is our prioritization of the SLT services action and increase the supply of the quality SLT cessation and decrease the, so that we can decrease the prevalence of the SLT use and the better health outcomes could be harnessed. Evidence suggests that cultural acceptability, normative attitudes towards the tobacco use and lack of understanding of the health effects and addictiveness of the are the factors which have influenced the tobacco use, SLT use among the Indian communities. According to the focus group discussion, which was conducted by the qualitative study conducted by the Murthy et al. 2018, which studied the perception of the smokeless tobacco users and the healthcare providers regarding the prevalence of SLT in the community, awareness of its adverse effects and challenges for cessation. Users and the service providers were more or less similar regarding the extent of SLT use in the community. There was inadequate knowledge of the harm from SLT use, both among the SLT users as well as healthcare providers. And this focus group discussion revealed how high positive expectancies from the smokeless tobacco use and low risk perception. There was a low demand for assistance to quit. So the themes were of the focus group discussion, reason for use and the continuation. So for the female, the initiation, that was the role model in the family or the society, feel warm or to reduce discomfort after a meal. And the factor which continued were the because of liking it or to become a habit or the overcome the craving. And among the male, the initiation, it was because of the peers, curiosity, time pass, which from the smoking to the smokeless. So this is how a switch over product from smoking to the smokeless. And continuation, kick their habit they got, it's having become a habit of craving. Adverse effects of SLT use, felt SLT use caused no discomfort among the females, whereas males, very few had themselves perceived any discomfort. However, they had several benefits from tobacco use. The positive expectancies were high. So what is the need for tobacco cessation? So among the females, they did not feel the need to stop or take the treatment and had not heard or been exposed to any preventive program. Whereas among the males, most felt that there was no treatment for cessation. Rising prices may discourage their use. So the user perception of SLT, switching from smoking or alternative smoking, can achieve and work where their hands are engaged in doing some other work. So it is considered as a cheap luxury and a point of sale advertising. And since they are like less expensive compared to the combustible tobacco products, a financial perspective. So what were the adverse consequences of perception of use? Women, they were low awareness was reported, cheap luxury, and the high expectancies, positive expectancies were high among the men compared to the risk. So the here positive expectancies from smokeless tobacco were the enjoyment, time pass, overcome the boredom, relief of tiredness, mood relief, habit, and ease of the bowel movement. The factors responsible for the so like here can still see the bar here.
Yes, it's still visible there.
Still visible, na?
Yeah.
1 minute. The perceived benefits like the social and the cultural, making strategies of the tobacco companies to promote smokeless tobacco as a safer alternative to combustible and the surrogate advertisement. So this was reported by the Sulian Kachi RA, and knowledge of the health effects of tobacco versus perceived harm on work or their health varies among the combustible tobacco users and the smokeless tobacco users. Misconception of smokeless tobacco as a safer has led to acceptability of these products when compared to the combustible ones. This was reported by the Mehrotra R study in the Cancer Control Journal. Often individuals with initiate use due to the lesser perceived harm on health from smokeless tobacco use as compared to other methods of tobacco consumption, such as smoking cigarettes and the BDs. Initiation of tobacco use in women often occurs during pregnancy, as believed are often held by the peers, family, and others that tobacco can provide the positive health benefits and relief from common elements and distress during pregnancy, such as nausea, vomiting, and constipation. This was reported by the Shalini Singh et al. Study in 2020. In a study conducted among married women at Mumbai, the SLT use was found to be attributed to reduce the stress, providing pleasure, associated companionship with the peers at workplace and in the neighborhood, and increasing the energy for workload and suppressing the hunger when dietary requirements were not met. So this is what in the introduction Vivek had told that how the smokeless tobacco is linked with the food. So the tobacco quit status and cessation. Quitting perception among tobacco users is influenced by various factors. Even though SLT users were highly motivated to quit, they were unsuccessful due to socio-environmental. This is...
Ma'am, I think it's okay. You can continue the presentation.
But you cannot see that part, na?
Yeah,
Mostly
only a
within the slide.
small part is not
it's been
visible, but I
hiding
think the
actually.
majority,
Okay,
we can see
I'll
the
just go
slides
ahead with
except
that.
that.
Okay.
Yeah.
So tobacco quit status and challenge. Quitting perception among tobacco users is influenced by various factors. Even though the users were highly motivated to quit, they were unsuccessful due to this strong socio-environmental influence. Persistent driving factors to continue consumption, lack of formal cessation resources, and the support. This was reported by Siddiqui et al. In 2021. Debar and Aghi 2013 study participants anticipated quitting to be extremely challenging, and especially the Indian participants had negative perception towards quitting and believed smokeless tobacco actually improved their health. The smokeless tobacco initiation cessation, so when it was compared, so like here the first daily initiation and the routine, it was compared among the 3 Southeast Asian countries. So they were the exclusive smokeless tobacco users for at least 25 days in the past month. Adult users were interviewed from the Bangladesh, India, and the Pakistan. So the length of the smokeless tobacco, you can see that even in the region also there is a difference. Like the length of smokeless tobacco use was for 40 years, 45 years among men, and whereas for in India 1.5 to 6 years among women, and 10 years among the Pakistan. Type of the smokeless tobacco product used in Bangladesh was pan with zarda, and in India khaini and gutka were commonly used, and in Pakistan Naswar and Peshawar and gutka and the Karachi. The regional disparity was seen even in the Pakistan itself. The frequency or the number of times per day. So you can make out that the frequency of use among women was less compared to the men. In Bangladesh, it was for 4 to 8 times versus 15 to 40 times among men, and 2 to 3 times among women, and 7 to 8 times among men. And Pakistan, it was 5 to 6 times among women, and 25 to 30 times among men. So here the first daily intake integrated in the morning routine, while later on it was either with the colleagues or the family. Higher consumption was seen among the social gatherings and weddings, even in presence of where the non-users were there. And they were widely available in all these 3 countries and affordable. Knowledge level of SLT content varied. The participant offered the detailed description, like what is there present in the betel pan tobacco betel quid, which is commonly used. So, or else the commercially available one. Men typically had the better knowledge through previous absorption of the product preparation or recognition of contents through the smell and the taste. Low awareness of systemic health risks, reporting headaches, chest pain, breathing difficulties, digestion problem, and feeling weak. Many noted that like the use of the pregnancy pose risk for the unborn child. Some women from all 3 countries reported their use of the smokeless tobacco during pregnancy without any apparent adverse effects. The oral health risks reported were blackened teeth, halitosis, gum disease, mouth ulcers, oral cancer, and thinning of the mouth skin. Risk could be mitigated by mouth, and they had a perception that these risks could be mitigated if they rinse their mouth after using a smokeless tobacco. Knowledge of the health risk and ingredients likely came from health warning in the media, while for some it was the visit to the doctor who had advised against the ongoing use due to the person risk. As far as the smokeless tobacco cessation is concerned, all reported strong cessation motivation, and they had almost 1 to 20 failed quit attempts, which had for a very short duration. So they attributed it was because of ease of purchasing the tobacco, access, tobacco dependency, and lack of the institutional support. No participants had sufficient support when trying to quit. And then most of the perceived doctors and other healthcare professionals are best placed to support the cessation. Cessation might be associated with fear of disapproval and the stigmatization. And like family and the work supervisors, wherever they'd ask them not to use, so the concealment of tobacco use was reported. And religious belief was one of the positive drive for the quit attempts. And only people who they had a perception belief that those who are addicted or already unwell would be at risk of the harm. So they thought like, since I am healthy, I may not get sick. Cessation intentions impeded by a positive physical sensation from the SLT use, negative physical withdrawal effect. They felt addicted and powerlessness to stop. The positive drivers for cessation were also reported to improve the oral health, since many of them had reported of the oral health risk, providing a role model for younger generation, and the financial benefits. However, these were quite inefficient to support the successful cessation. So this shows that the SLT use among South Asian has been culturally acceptable with strong social foundation. Addiction perception among smokeless or combustion at tertiary hospital. More than half of the participants perceived that they are addicted to tobacco. perception of addiction was significantly lower among SLT users compared to the combustible tobacco users. Some reason for such perception may be the cultural acceptability, normative attitudes toward tobacco use, and lack of understanding of the health effects and addictiveness of smokeless tobacco. And a significant increase in the pursued addiction was seen as the age increased. Perception of being addicted to tobacco products higher among individuals with higher level of education and among the older ones. The research on addiction perception show that some tobacco users perceive themselves as being addicted to tobacco if they use it daily and find it difficult to stop use for more than a day. Social behaviors as they need to use tobacco at times or in places where it is forbidden. This study focused on self-perception of addiction. The context of tobacco use may be associated with the shame, stigma, or the bias. So what this study has implication, the need to provide information and education on the addictive potential of all types of tobacco products in India, using strategies that could include display of information through pictorial health warning labels on tobacco products and the awareness programs. They should be designed and targeted particularly to the smokeless tobacco users, probable initiators, the youth, women, and those with a very little education. It is potentially useful for targeting the primary prevention campaigns towards the individuals with low or no education and the younger individuals. For future community education and tobacco addiction treatments, it is very important to understand the addiction perception in relation to the specific types of the tobacco products. So here we can see that the M-Health intervention for smokeless tobacco cessation, the qualitative study using the in-depth interviews with the tobacco users and primary care physician and with the counselors was conducted at the 4 urban primary health centers at Behrampur, Odisha. The participant considered mobile message counseling helpful and acceptable. Not having a mobile phone and illiteracy were identified as the barriers, while ease of access and rise of popularity of social media applications were considered facilitators to the use of M-Health for quitting the tobacco. Participants preferred messages that were pictorial, short, simple in local language, and tailored to the individual needs. This is the first study that provides evidence within the Indian context that text messaging platform may be used for delivering an SLT cessation intervention. The integration of a theoretical basis and research for finding from the target users can guide the future intervention development. So what are the social influence to continue SLT use include the husband's use, family. In another study, what were the challenges which were faced by the Indian women readiness to quit smokeless tobacco use? So here the role of the husband's use, family influence, and positive beliefs and norms about use. Pressure to quit from significant others have and influenced past quit attempts, but media had no effect on the reported behavior. 4 groups represented different readiness to quit status based on intention to quit past quit attempts. 17% had no intention to quitting or reducing. Their husbands were more likely to be to the tobacco users. Half of the sample had attempted quit or reduce the tobacco and intended to do in the future. They were depressed. They reported to the low emotional status, depressed, and 15% had tried to quit but did not intend to gain. So here you can say report that the one of the psychiatric comorbidity also, the depression was also reported among women. Correlates were positive beliefs and norms about SLT and the withdrawal symptoms. The conclusion derived from this cessation program should be made available to the women, addressing the correlates of this study with the women's readiness to quit status. Results suggest that need for more complex social contextual approaches to sustain the cessation of SLT use, including addressing the depression and withdrawal, improved media message and campaigns tailored to women and support the family members. So, Vivek, are you covering this in the introduction part?
Yeah, ma'am, we've already covered this in the
Okay,
introduction
then I'll
part.
skip this.
I would request you to
Yeah.
kind of like
So
wrap
what
it
are the
in another
patient's
1-2
challenges
minutes.
to quit
Yeah.
tobacco? Why people do not change? There is an interplay of the four forces which influence the change in a behavior. So here forces which keep the person in his current behavior is what they like about their current behavior and what they fear about the new behavior. The forces which encourage the change to a new behavior includes what they dislike about the current behavior and what they imagine the advantage of the new behavior would be. These perception and feelings are not rigid and stable. At various stages in their lives, they tend to attach more or less emotional significance to each other of these four factors. So what is the role of the healthcare provider here? So continual balancing with the risk and the decision balance from one end to another. So here the clinician goal should be tip the balance in favor of the decision to the change and adapt the smokeless tobacco quitting behavior. So here we can decision balance. They can make the what are the advantages of using the current smokeless tobacco, what are the anticipated disadvantages, and what are the change. Like if they quit the tobacco, what would be the advantages and what would be the disadvantages. And it not only for them, but also the consequence of the self and to the others, and how they feel about themselves and how they how others feel about themselves if they change the behavior. So evidence-based approaches to quitting, Cochrane review 34, that we have the include behavioral support, varenicline and nicotine replacement therapy products. The researchers concluded that varenicline, nicotine lozenges, when behavioral intervention may help smokeless tobacco users to quit. Neither nicotine patches nor nicotine gum were seen to increase the level of abstinence. The challenge is that these trials were carried among the users of US and the Swedish products. No trial involving the South Asian smokeless tobacco products, which differed markedly in their composition and addictiveness, are conducted. So this shows a gap even in the evidence. So however, the NICE guidance recommends commissioning a tailored cessation services in areas of identified need with their planning and implementation involving the local organization, consultation with the local communities, local healthcare and the dental teams, as well as community-based health professionals, pharmacists, midwives, and health visitors should be able to provide very brief advice and behavioral support to aid quit attempts using brief interventions for SLT cessation, followed by the referral to the specialist tobacco cessation services. So the brief interventions you can focusing on enhancing the tobacco users' motivation to change and connecting them with the evidence-based resources to make the next quit attempts a success, which is compromising of the 5 A's to help the patients quit, and those who are not willing to quit the 5 R's. So ask every tobacco user and document, advise tobacco user to quit, assist counseling and pharmacotherapy, assess their readiness to quit, and arrange for the follow-up. So here the targeted quit support comprise of the cessation service, brief interventions, and working with the communities. If the time won't permit, go for the ask, advise, and refer to help the patients, ask about the tobacco use, advise to quit, and refer to the outside help. Ask, advise, and connect. So you can connect it to the health resources or else to the electronic health records. And the tobacco cessation specialists, counselors, medical professionals can address the comorbidities, physical and the psychiatric. So you can always refer them even to the M cessation program to quit tobacco for life by motivating them to give the connect through the M cessation program or else through the National Tobacco Quit Line Services. The 5A methods is considered to be the gold standard of tobacco cessation intervention. So we had to make it as a gold standard to ask every patient, client about the tobacco use, current and the past, and even the second-hand exposure. And our advice should be strong, clear, and the personalized. And we have to assess the patient's willingness to quit attempt, make the quit attempt and the nicotine dependence, and assist them with the medication, counseling, and referral. And we had to do the arrange for the follow-up as well. So we're not only telling about the harms or the risk associated with the tobacco use, we had to speak them about the benefits or the margin of gain if they quit the tobacco. So for example, the few of the gains like here, as far as the smokeless tobacco is concerned, in South Asia, smokeless tobacco users are at 5 times the risk developing the oral cancer. So we can always motivate them that what would be the gain if they quit the tobacco. After quitting, the risk of development of oral cancer is cut in the half, and leukoplakia, periodontal disease, melanosis, even the bad breath, halitosis, staining of teeth, and even the aesthetic component. So all these things could be correlated. So what would be the benefits?
Ma'am,
So
can
the
we
best
summarize
practice,
in
finish.
another 1-2
Yeah.
minutes? Yeah, because we
The
have
best
Dr. Amit
practices,
also.
like here the M tobacco cessation intervention, collaboration with the government, WHO, ITU, which is there in the, and then National Tobacco Cessation Quit Line number, which are now available at the 4 places. So by giving a connecting them to the, which are printed on National Tobacco Quit Line number, which is printed on the packages of the tobacco products, and like promoting tobacco cessation in India by integrating brief advice. So Article 14, tobacco is the barriers. The 180 member countries refers to tobacco cessation as one of the key demand reduction measures. Currently, the progress of it in India is categorized as intermediate, slow, and often partial. And provision of the infrastructure, what it contains, it guidelines contains the provision of an infrastructure that support TCS and treatment for tobacco dependence, and population level approaches, system approach, enabling all health facilities, healthcare workers to deliver tobacco cessation to the individuals in a stepwise manner, robust monitoring and evaluation of the cessation and their outcomes, international collaboration so that most effective cessation measures get implemented. Cessation is also promoted as one of the key components of WHO design strategy under the acronym Offer Help to Quit the Tobacco. So the current status of the tobacco cessation, like there are around about TCs available at more than 500 primary healthcare level, country NTCP program, international health mission, and the other along with the national health programs, de-action services provided by the psychiatry department and units of the medical colleges, clinics run by the dentist and trained under TI and the IDA, TCC run by the private and the corporate health facilities, dental colleges, and NRT as a provision of the pharmacological treatment facility at the district level under NTCP, cessation counseling for the registered users through National Tobacco Quit Line number and the M cessation. Challenges, there is a sketchy delivery even by the tertiary government health sector, and then the absolute lack of the TCCs even under secondary and tertiary levels, and which that now spans for the 70% of the entire country's entire health system, suboptimal participation of healthcare professionals, lack of intent of part of the tobacco users to quit the tobacco, lack of messaging through the IEC or the mass media campus under tobacco to the government and the civilians or the civil societies. National health programs has been converged under the National Health Mission, but these do not have a specific mandate on the targets to be achieved. So the novel products have the new challenges, like one of them is the snus or the smokeless tobacco products. So although these products are potentially harmful and people do not use them, should not start FDA granted modified risk tobacco products, the snus smokeless tobacco products. This means that these products may be advertised with information and their lower risk of certain health effects when compared to the smoking the cigarettes. So like here, the one of the studies reported that high levels of the tobacco-specific nitrosamine and nicotine in chinekine, a product marketed as NUS, a matrix of reduced risk nicotine delivery systems in the name of the harm reduction. So this was conducted by the Irina Stephanie and the Prakash Gupta et al. Study. So they reported that it contained the high levels of the tobacco-specific nitrosamines and biologically available nicotine, and interventions are urgently needed to educate current potential consumer of this product and to prevent mislabeling of the similar harmful products as NUS with the claims of the risk reduction. So here, this is smokeless tobacco. You can see that the snus, dip, and the plug and the areva.
Ma'am, I think we can pause here for a bit. We can definitely come back for question and
here,
answers.
like one of the how we can harness our practices at the day-to-day life. We can I'm just giving one of the examples wherein the users were this was conducted for the drivers association, wherein they were taught how to do the self-examination to identify the early users of the smokeless tobacco use, and they were taught how to even to use call to the motivated to call to the National Tobacco Quit Line number, how to connect to the M cessation program, and they were guided to install the WHO Quit Tobacco app. So we can always have the one simple way that you currently use the tobacco challenge, more people want to quit, but participation by the healthcare provider is still optimal. So the opportunity exists. So we need to be the game changer in to achieve the end game of the tobacco in India. Thank you.
Thank you so much, Aruna ma'am, for giving a very
Yeah,
comprehensive
no,
overview of smokeless tobacco cessation, both in Southeast Asia and also in the Indian context. Not only mentioning the socio-cultural and environmental challenges, but also health system challenges in strengthening cessation activities, both from a clinician's perspective, but and also from a larger societal perspective. We'll now move on to our next speaker, Dr. Amit Yadav.
I'll stop share. I'll stop share.
Yeah,
Hmm.
we've looked at the on-ground implementation challenges. We'll now move on to slightly larger macro policy and legal challenges that Amit will be taking us through. Over to you, Dr. Amit.
Thanks, Vivek. Can you see my slide?
Yes.
Okay, so I'll be very quick, and I think since there are not many people, and those who are there, I would prefer that they ask questions, and I'll just put some kind of thoughts for them. And if we look at tobacco control, we already have COTPA as one of the law which is available. And what is the main idea or preamble of the COTPA suggests? To prohibit the consumption of cigarettes and other tobacco products which are injurious to health, with a view of achieving the goals of Article 47 of the Constitution. Okay, so this is already we are having in COTPA, which is in 2003. Then in 2006, we came up with the food safety law, and in 2011, the food safety law said that you cannot mix tobacco and nicotine as an ingredient in any food product, resulting thereby ban on most of the gutka products especially. But what industry did was they separated tobacco and pan masala, and they started selling in separate pouches, and now they are selling them differently. Earlier, they were selling a joint packs, no co-joint packs of pan masala and SLT product to be mixed and as a pre-mix. Sorry, as a separate mixed product, but now they are selling it separately. 3.1 also suggests that anti-caking agents should also not be put in pan masalas and food products like carbonates of calcium and magnesium. They have prescribed a limit, and anything beyond that is again also prohibited. Drugs and Cosmetic Act since 1992 prohibits using tobacco in toothpaste and any tooth powder or dentifrice that is used. So these are legal provisions already there, but we face challenges in their implementation, and the industry have diversified and stressed itself, or started sharing the same brand with other products, and they continue to promote the SLT brands. That becomes a big challenge for us. So this is the law as for the food safety. Tobacco, nicotine shall not be used as ingredient. Even the Supreme Court suggested that you should not sell them if you are aware that these are going to be mixed and used. Again, but there are violations. This you are already aware. So, what kind of tobacco, SLT tobacco are used? So this is already now, I think Dr. Aruna also spoke about. What is the level of user? We have 20 crore SLT users in India, and 90% of them are in 13 states. So it's a big challenge for these 13 states, and the highest number of SLT users are in, Uttar Pradesh, Maharashtra, Bihar, Madhya Pradesh, and West Bengal. So, and what it again during COVID, we realized that what does SLT results in? No, it induces spitting. Now, spitting itself becomes a big public health problem or a communicable disease problem, and we saw that during COVID, sale and use of tobacco in public places, and especially sale of tobacco during first part of the COVID was banned completely. And there was this appeal from ICMR as well, not to consume and spit smokeless tobacco in public, and this was adopted by several states. So all of these states and union territories, they issued specific orders. So these are the states which have banned during the COVID period, and then yeah. So if we look at food safety law, and I think it is a later part of the law, and it says it has an overriding effect on all other food related laws. So if there is anyone who is using food item and putting tobacco in it, So it overrides even the provisions of COTPA, where pan masala is written as one of tobacco products. So I know it has that effect of overriding, and any pan masala or gutka and these kind of tobacco product should be omitted from such schedule, and they should not be available. Uh, Several states have issued, and even I think the Allahabad High Court also issued that prohibitory orders, no other things, and it varies from 25,000 to 5 lakh rupees. That is under FSSA. And there is a designated officer who can take action under food safety, and they are the food safety commissioner or your district food safety officers. All of them can do that. So other than the food safety law, we also have, as Dr. Arna was mentioning about um, electronic cigarette or other nicotine products. So these are also smokeless tobacco alternatives which are there, but nicotine is also banned in our country in several parts as a poison. No, and electronic cigarette is completely banned under the Act in 2019. And then we also have provisions to regulate them under Municipal Solid Waste Management Act, under environmental pollution, where you cannot package these products in plastic. And similarly, the plastic waste management rule were changed in 2011, and they also required that it should not be packaged in plastic pouch. And recently, even the Central Pollution Control Board, through an order from the NGT, they've asked all even the cigarette butts and BD butts where plastic is engaged not to be used, and they are creating SOPs, and like Karnataka has already started developing SOP, and they are going to implement it. Another provision of law is Consumer Protection Act. While we all look at different kind of laws, but we do not demand that protection of law when it comes to the implications. So, if the children are exposed, if the adults are exposed to these products, and they are sold in a surrogate manner, it is a violation of consumer rights, and people can go to the court and seek redressal and ask for compensation. I think Dr. Yogesh is on the call, and he has worked on Consumer Protection Act, and producers liability or product liability concepts. I think we need to develop them, and I think law schools have a big role on developing that, so that people can actually feel comfortable and feel assured that these laws work, and we can get redressal. So these are some of, I think, the legal provisions. In terms of challenges, what I would say that is is that its implementation becomes a very big problem, and several of these industry tactics that we see every time, like if I give an example of Vimal Pan Masala and Vimal Ilaichi and then Vimal Gutka, and same thing happens with Chaini or Kamla Pasand or Rajsri, anything. So these are one major challenge that we look at. I did a very small write-up on how Baba actually does a tobacco and a non-tobacco kind of a product, and promotes the non-tobacco product through be it Salman Khan or Ajay Devgan or anybody. This is really is the big challenge when we talk about SLT control in India. So I think with that I will end, and I think I'll if there are questions or discussions, I'll leave room for that. Thank you so much.
Thank you so much, Dr. Amit, for taking us through a walkthrough on the kind of laws and regulations that are in place, and the kind of challenges that they go through in terms of implementation. We now move on to question and answer, and if anybody would like to come in, unmute themselves, or ask any questions, they can raise their hands. We also have the chat box with a few comments, so we can take them as well. But if anybody would like to come in and ask their questions, please raise your hand. You can unmute themselves. Prabhakara is asking, do we have any specific tobacco cessation service for SLT dependents? I think this is directed to Dr. Aruna ma'am.
So currently, like as far as I know, like holistically, they have been addressed, the tobacco cessation centers, both for the smoking as well as the smokeless tobacco products. So now the new challenge, it is now through even to handle the nicotine delivery products also, ENDS, and also I think most of these challenges are addressed at a tertiary level hospitals. As far as I know, like the exclusive smokeless tobacco cessation centers are not there. Like.
Thanks,
Prabhakara, I hope that
thanks,
answers.
thanks, Dr. Aruna.
Yeah, sir. Like, yeah, because like even at Bangalore also, like even if we see that many of these addiction centers, if they're attached to the even to the NIMHANS, institution of national importance. So
Correct.
wherein like if the person has any psychiatric comorbidity, as well as the use with the use of smoking or the use of smokeless tobacco products with other substance uses and the psychiatric comorbidity, so they are addressed at the higher level over there. So like regularly, like at the secondary and the tertiary level of hospitals, these NTCP programs, the cessation clinics are available. And at least if you take in the district hospital, like in Karnataka, not Bangalore, now KC General Hospital has a TCC center. So, and then again, like the so this is how it is functioning under the National Tobacco Control Program. But as far as my knowledge goes, exclusive smokeless tobacco cessation centers, I'm not aware, sir.
No, actually, yeah, I'm working in the National Tobacco Control Program as a part of the union.
Yes, sir.
So my point here is, see, whatever NRT services we are giving in tobacco cessation center throughout India, it is basically on the smoking smokers.
Yes,
smoking
sir.
addictions, not exactly for the SLT. Whatever patches we are giving, whatever nicotine gums we are giving, 2 mg, 7 mg, whatever mgs, it is only for the smoking. There is no tested, proved treatment for SLT in India.
I told it in the gaps also in the evidence-based measures. So like the varenicline and the tobacco nicotine lozenges are shown along with the behavioral support have shown the good smokeless tobacco cessation outcomes.
But is it government consider those treatment?
Sir, as at NIMHANS and all, like because where I did my course and all, so even their SOPs, like they are prescribing for the smokeless tobacco cessation.
But I have visited many times NIMHANS, and I am in the NIMHANS campus only. But as far as my understanding, they are not giving any specific treatment for SLT dependent. So
they are
here,
like actually the smokeless tobacco dependence. So here the nicotine is addressed here. So based on the level of the dependence, whether a person has a low, medium, or the high level of dependence, the interventions are addressed. And pharmacotherapy is not the sole standalone therapy, because along with the pharmacotherapy, the behavioral support is very much essential.
Completely agree. Completely agree.
And the follow-up is essential. So here, even for the smokeless tobacco users, the nicotine lozenges and the varenicline have shown a proven efficacy in controlling the smokeless tobacco cessations.
Okay. My second question was so occupation-based dependence, SLT, for example, bus driver, lorry drivers, truck drivers, taxi drivers. In fact, State Tobacco Control Cell, with the support from the union, we are proposing to work with the Karnataka Transport Department on the the SLT dependency. So, but we are not sure what kind of services other than this psychosocial support, communication, IEC, all those things. So what exactly support we have to provide them to come out from? Because I've done some one-to-one interview with the drivers and the conductors. They are saying, so if they have not taken the SLT during while driving the vehicle, they cannot drive the vehicle. They feel sleepy. So that's why they are taking SLT or pan masala. So how to deal with such kind of situations?
Sir, actually, one of the slides I had projected at the end of the presentation. So wherein the recent one of the health programs. So it was an annual health checkup program for all the transporter, the drivers association, which was held at the Basveshwar Nagar here only. Okay. So here, there I utilized the platform to sensitize them about the tobacco use. So here, I never use any of the expensive tools or anything. I just asked them to give the mirror and then asked them to give the tobacco products they were using. So like they shared the tobacco smoking form of tobacco products as well as the smokeless form of the tobacco products. They were just hung above and below the mirror, and then I just asked them to what is written on the read on that, and then they could read. And I asked them like, did they contact the Quitline service, National Tobacco Quitline Service, the number which is printed on the packages of the tobacco products? Many of them denied. They said like, we don't want to contact. So we are happy with the user. As you said, like most of them had a positive expectancy of using the smokeless tobacco or the tobacco in the smoking form also, just to keep them the alert, concentration. And sometimes they said like, even to overcome the frustration if they won't get the ride.
Yeah.
So they said like, we smoke more to overcome the anxiety and the stress. So
Correct.
then like here, like one of the citation I used was like, ಒತ್ತಡಕ್ಕೆ ಉತ್ತರ ತಂಬಾಕು ಅಲ್ಲ. So
Okay.
then again in that group, so I helped them to do the self-examination of the oral cavity in front of the mirror for the earliest indicators of the tobacco use, as well as to anticipate if they detect any early sign of the oral cancer, which is printed on the packages of the smokeless tobacco. So
Right.
they were taught, sir, on the how to do the oral self-examination. So in their group only, like one of them had oral cancer 9 months back, and he shared his experience. So
Okay.
he is like, one video also they made it, and they said like this was one of the first of its event which was organized for them. And then he shared his experience that he said like he had so much of craving that even while going for the treatment of surgery for the oral cancer, he had a chew in his mouth. And now he shared his experience that after 9 months of the surgery, he had the craving and he experienced withdrawal symptoms because of the weakness or because of the components which affected his quality of life, followed by the surgery, chemotherapy, and the radiation therapy. He shared his feelings, please do not use. And he showed his hands where the grass was taken, and he motivated all his colleagues that please quit the tobacco. I know that it is very difficult, and all of us have made more than 20 quit attempts, but none of us could succeed. And I asked them, like, since I also had a time constraint, so I did the like 3 A's: ask, advise, and connect. And I motivated them to connect to the national quit line number. M cessation contact number was shared with them, and I asked, and they were motivated. Whoever had a space in their gadget, they were. I guided them to install the WHO Quit Tobacco Cessation app also as well, sir.
Super.
And this, they have made a WhatsApp group among the workers. So whatever these transport drivers and the president who had organized this, he asked for all the resources, and it is shared. So through their like network, they are sharing like the how to control the craving management, withdrawal management, and few of the IEC materials have been shared with them, sir.
Thank you, ma'am. Thanks for it.
Thanks. So wherever we get an opportunity, it is the best thing to give the like sensitize a user about the harms of the use of the tobacco and what the rewards. So rewards are also very much essential, because nobody will pursue that they'll get a oral cancer like which is printed on the tobacco packages of tobacco product. They say, I am healthy, I won't get.
Correct. So kindly share your number, ma'am.
Sir, I would
I'll...
wish to connect with you, sir, and I would share even with I have your mail, sir, like mail.
Oh, thank you.
I had contacted you regarding the questionnaire, sir.
Oh, thank you, ma'am. Thank you, sorry.
I'll do that, sir.
Thank you, Aruna ma'am and Prabhakara, for your question. We have one more question by Arundhati ma'am. I think this is referring, for Dr. Amit. What is the status of COTPA amendment? Ma'am, if you'd like to be more specific, you could unmute and ask Arundhati ma'am. Amit, would you like to take that question?
I can only say that it is still under consideration and public consultation. The government has yet not introduced it in Parliament. We are all also waiting for it to move forward. And I think different states are also moving forward. I hope that the states will take also codified amendment forward.
Okay. We have a comment saying community and group resistance is seen in larger context over tobacco and SLT control. I think that was more of a comment than a question. Yeah. Any other questions? Can unmute.
So this
and
is because of the cross like social cultural acceptance of the smokeless tobacco products. So they stigmatize the like cannabis, alcohol, and other higher product substance use. But as far as the tobacco is concerned, it is socially acceptable. So the new norm should be to denormalize this cultural beliefs and the norms.
Thanks, ma'am. Amit, I had one question for you in terms of SLT control and the fact that now at this point in time, how are we grappling with industry interference when it comes to SLT? I mean, I read a news article a few months ago that talked about how the courts have sort of, overturned gutka ban in some states. I think it was the Delhi and Madras High Court, if I'm not mistaken. Amit, you could clarify that. But it mentioned a certain degree of concern of the fact that it took decades time and worth of a lot of advocacy in banning gutka, but now the courts have been involved in and have taken a different turn. So how do you look at that in terms of policy as well as implementation of SLT control in India? Amit, were you able to hear me?
Can you repeat, Vivek?
Yeah. So my question to you was of the fact that I recently read an article, a newspaper article, that the courts were somehow involved in overturning the gutka ban. I think it was the Delhi and Madras High Court. And in that context, I wanted to know your thoughts on one is industry interference, that we have increasing in kind of industry interference in SLT, and how you look at that, and secondly, in terms of implementation policy as well as implementation concerning this overturning of the ban. How do you see things moving forward?
See, the overturning of ban has not actually in effect happened anywhere. In Delhi, they had overturned, and in Tamil Nadu also. I think in Andhra Pradesh, but law of the land continues to be the same, that you cannot sell gutka, you cannot sell food with tobacco or nicotine. The judgment of the Delhi High Court was reversed by a division bench. So it was a single judge judgment. It was appealed, and a double bench of judges, they reversed the judgment, and then they said, and that judgment is really very nicely given, that it is harmful, and it is within the law also technically as well, that when it is a ban and it is a hazardous product, and if the states are also banning it year-wise also, then also there is no problem, because there is already a notification suggesting that it is completely impermissible and at the national level. So that is a very good judgment there. As I was telling, that it is the implementation of the provisions becomes a problem. So just to let the people on the call also know, and to, just to make a point, that selling of pan, pan is a general thing. People eat pan in India everywhere, and you have pan shops everywhere in India. The moment a pan wala or this pan vendor, the moment he puts jarda on your pan, and gives it to you and takes money from you, he has contaminated or he has violated the provisions of Food Safety Act. But this awareness to the person who is eating and the person who is selling is not there, and even the enforcers will not go and say, okay, how come you are putting tobacco in the pan? No. Similarly, if you see that tomorrow you find tambaku peda, no, there's a Dharwad peda is very famous in Karnataka, and if you tomorrow have a tambaku peda, which is like a Dharwad peda mixed with tobacco, will the food safety department still be okay with that? Say, okay, this is fine. No, you are selling with mixed with tobacco. So it happens, no, it's the same thing, because in pan you are mixing all the edible items. Your pan is an edible leaf, and even the areca nut, which is carcinogenic, but it is still a food item, and it's a food product. No, it's considered. Then you have all other what is it called, cinnamon
The spices.
spices, cardamom, clove, and all of that. All of these are and cherry and some sweet this chaff and all that. So all of this is edible item, and you're putting tobacco there, and it is violation. But this is the problem. Similar to how we look at the Juvenile Justice Act, and it is banned, it is prohibited to give tobacco to a person under the age of 18 years. But we see that people are giving, and people are asking young people to bring their tobacco and get it, send it to somebody and all that. Whereas the law says that if you do it, you are supposed to be punished with 7 years imprisonment and 1 lakh rupees fine. But it is day in, day out, it is being violated everywhere. I think that is the area where awareness of the law, awareness of these provisions, and behavior change or social behavior change, social cultural behavior change is required. I think that is where I think the people who are engaged in IEC, BCC, they should work on this also, and inform people about the import of these provisions.
Sir, in one
Thanks,
of the
Amit.
studies, even the content of the pan, actually, so women were not, they couldn't identify more than 1 or 2 products. Men identified better, and they could perceive what is there in it either through the smell, aroma, and the taste of it. So there is a gender-wise disparity also. So zarda wala pan and non-zarda wala pan,
Yeah.
Thanks, Amit and Aruna. I think we have one more question, and we will take that as the last question for this webinar. And that's directed towards Dr. Aruna ma'am. The question is, what may be the ratio between NFHS tobacco or SLT users and % of people seeking SLT cessation?
Achha, National Family Health Survey report, and the gaps in the cessation, advice.
What's the ratio between the number of people who are tobacco users as per the NFHS data vis-a-vis the percentage of people seeking SLT cessation?
Yeah, one of the key findings reported was the under-reporting was seen because especially among the women in the NFHS survey, because of the social desirability. So, and again, exactly I'm not well versed with the numbers actually, but wherever it is, there is a need for the cessation is there, but this need has to be projected into demand. Demanding for the cessation services were very low, especially for the smokeless tobacco cessation.
Thanks, ma'am.
I think in terms of cessation, I think there is even whatever number of people wanting to quit, it is still very high. As per the GATS, we see that almost 50% of men SLT users, and almost more than 50%, it is 53%, and 42% of women tobacco users, they plan to quit. Now, plan versus advice to quit by a health care provider, only 33% and 28% male female were advised to quit. So let us say if 20 crore, if we take the tobacco users, then 50% of them actually want to quit tobacco use, and only 33 have been advised to quit tobacco SLT use. So that is the gap, and I think that's the big gap. And thankfully, I think cessation is being given now due consideration,
Important.
and it is being discussed and it is being promoted, I think it is going to change that scenario, because we already have 27 crore tobacco users, not of the 20 crore SLT users. So we need to think about them.
So the
if we are,
those who are in the stage of the pre-contemplation, who are not thinking of quitting tobacco, so they are more than 48% among the smokeless tobacco users compared to the
Yeah.
smoking forms. Sir.
yeah.
So they are the happy users.
Thank you.
Thanks, Dr. Aruna and Dr. Amit. We have one last question, after which we will be ending the webinar. We have it for Dr. Amit. Is there any nationwide data available regarding the conviction rate under Section 77 of the Juvenile Justice Act?
I don't think there are many, but if you say that Section 77, then there might be for drugs and other things. I think the best way to look at it is the Central Crime Reporting Board. No, I think CRB it is called, and you can look at that, and they give the data for all the thing, the National Crime Records Bureau. So if if that's needed, I can go and check. But I think for tobacco, it would still be not many, or even not one or two cases of conviction for selling tobacco, giving tobacco to minor. So that, but yes, there have been cases, but convictions, I'm not sure.
Thanks, Amit. So I think with this, we have come to the conclusion of our webinar today. Thank you so much, Dr. Aruna and Dr. Amit, for your valuable time as well as your expertise. I know we started a little bit late and we ended also late, but I do hope we ended on a really good note, considering that we discussed a lot of in-depth on SLT control and both the policy as well as the implementation challenges. I thank everyone who participated for this webinar, the participants for registering and joining. And if you are interested in the field of tobacco control and if you'd like to know more about the work that we are doing at IPH, you can definitely go to our website, iphindia.org. And you can check our updates on all our social media channels, IPH India. So thank you once again to everyone present here today, and I wish you the rest of a good rest of the day.